Everybody, just give me one moment here. Here we go. Okay, so good afternoon. Welcome to Court Connects. My name is Rochelle Weitzberg. I am a member of the Court Board of Directors, as Tina just told you. I am joined by my partner, Marianne Howie, who is also a member of the Court Board of Directors. And I would like to welcome you to Court Connects. Our session today is on how to do bedside teaching. I would like to introduce our speakers for today. First, Dr. Linda Regan is an associate professor of emergency medicine, vice chair for education, and has been the program director for the emergency program at Johns Hopkins since 2010. She is the inaugural program director for the combined emergency medicine and anesthesiology residency program and holds a joint appointment as an associate professor in the Department of Anesthesiology and Critical Care Medicine. Dr. Regan also runs the Medical Education Fellowship within the department. Dr. Regan graduated medical school at Johns Hopkins and completed her residency at NYU Bellevue. Her interests include a range of topics within medical education. While she has maintained a strong focus on teaching residents professionalism and communication skills, her current interests focus on resident assessment and the development of independent learning skills within residency. She is well known within Court as a speaker, a previous chair of the Best Practices track at the Annual Assembly, and previous member of the Board of Directors. She is currently a member of the RRC in emergency medicine and is an ABEM oral board examiner. Dr. Leah Bright is an assistant professor of emergency medicine and the associate program director for the emergency medicine residency program at Johns Hopkins. She graduated from medical school at Midwestern University and completed her residency at downstate Kings County. Dr. Bright's interests include curriculum development, resident-focused interactive learning, and the challenges of resident education and wellness in stressed emergency departments. She also is working on collaborative research for the future role of palliative care in emergency medicine and patient safety by developing a standardized handoff for emergency medicine. Dr. Bright's contributions to Court include presentations at the national conferences and chairing the four-year Community of Practice Committee. I'm going to ask you all to just self-mute your computers for the duration of the lecture, and we will absolutely open the floor up to questions when the presentation is completed. And I will now turn the floor over to Dr. Bright and Dr. Regan.
Hi everybody, how are you? We are coming from Baltimore, lovely, beautiful city. And we're going to talk about today the art of bedside teaching. So our introduction. I like this quote a lot, especially if you work with your neurosurgeons recently. The teaching is exhausting. It takes a lot of work and a lot of focus, which is why half the reason we may leave our shifts very tired at the end of the day. So our objectives, by the end of the hour, you will be able to talk about the challenges of teaching in our clinical areas, how adult learning theory can help you be a better bedside teacher, identify and discuss what teaching models are present in the literature, identify teachable moments to facilitate your bedside teaching, and hopefully incorporate new skills or approaches to be a better bedside teacher. So we kind of just guide you through what we try to do, and hopefully you'll walk away feeling like you have a better idea on how to manage your residents. The outline again today is the challenges of bedside teaching, know your learner, methods to remember, teachable moments, and of course, a conclusion. So this is often how I feel in the emergency department. We all sit in an open area, a lot of questions, a lot of answers, and a lot of trying to manage a lot of people at the same time. And I don't know if you have one of these. This is my ASCOM phone, which I decided to essentially double because it never ever stops ringing. And as we know, a lot of interruptions are not conducive to good teaching. And this is my monthly love letter from my people who work 9 to 5 and like to watch everything I do, my patients per hour, how fast my disposition times are, how fast I get them upstairs, how fast I turn fast track around. And being mildly competitive, I always want to do well and yet feel a little bit challenged on how am I going to improve these numbers to help my department, and because I can't help myself, and also teach and make my residents feel like we're learning on shift, not just pushing patients. So our challenges that we face when we're trying to teach in a very busy emergency department are our metrics, which we're all under, and putting out the fires. That has been recently, the nurses telling me that we ran out of urinals. I wasn't sure how to fix that one, but they came to tell me, hoping I would figure it out. Of course, our confidence and knowledge is a very well-known challenge, and of how to teach with limited time. And really, healthcare is not set up for teaching. Who teaches the teacher? How do we teach our residents, and who taught me?
So we don't want to make everyone feel like this is a losing battle or a sinking ship. Definitely, I think that when you think about teaching in the emergency department, we should very, very rapidly move to the thought that there is a bright side, which is that we're teaching adults. And adults are a certain group of people that come to you with some things we know about them already, that they learn really focused on a certain type of thing that we're going to talk about, which you may or may not have ever heard before. And if not, we'll talk about it right now, but in very minor detail. It's the principles of adult learning, otherwise known as andragogy. So there are 5 big key points that you should be thinking about when focusing on adult learners. And I will ask you the question that hopefully you have the same answer as me, which is, I don't think you can find a better environment in medicine than the emergency department to really find that you're hitting all these key points when you're teaching your learners, whether or not they're medical students or residents or our colleagues. So learners need to be involved. And obviously, when you're teaching a resident or a student in the emergency department, they're already actively involved in the care of patients in front of them. Learning is best for adults when it's already based on things that they know. They all come with previous experience. They've already seen a patient with chest pain before they see the next one with you. So really capitalizing on the foundation that they have and building upon that is key. Learning has to be relevant. So where is it relevant more so than when there's life and death at stake for their patients? And this, it gives you an opportunity to really find the opportunity to give your learners solutions to the problems that they're facing in real time. And then remembering that all of these adults are coming to you motivated because they want to do well. They want to be good doctors. They want to take good care of their patients. And so making sure that we're focused on rewarding positive things as well, because all of these learners are seeking to be successful. So how can you be most successful in teaching your adults? Well, it's remembering that, we just talked through those 5 criteria of andragogy or key points, but it's also understanding that you have to be sure you're hitting these criteria. We're going to go through them on the slides here. So learners have to feel like they're ready to learn. And if your learner is embarrassed, they're not going to be ready to hear what you have to say. So, if you need to walk into the back hallway, that's fine. If you're in front of a patient and someone says something wrong, that may not be the right time for you to correct them unless you've already established that that's the way it's going to work in front of the patient. So really understanding that they have to feel safe in order to learn. And therefore, this concept of learning readiness is really important for you to be paying attention to throughout the shift. If they have 3 critical care patients, that's probably not the right time to sit down and try to talk through searching the literature to find an answer. Learners really need to understand why they have to learn something. So, the other day we may be talking about the management of DKA and the plan for that patient that would be orders in 14 or 18 or 16 hours. Well, if you understand, let's say in your hospital, that you have boarders that are there for 2 days, they will not question why they need to know about order sets for the future, or why they need to learn how to put on PRN orders or Q2-hour blood gases, because they understand that it's important for the situation that they're in. That really links directly into this idea of relevance, and whether or not that relevance is what they're doing right now or what they're doing in the future. So I would think we would all agree that we'd probably never be able to find a medical student who would ask why they need to learn CPR. They all know why they need to learn it, because they may need to do it at some point, either on an ED rotation or up on the floor if someone has a cardiac arrest. So making sure that we're really focusing on providing relevance for people in learning. And this is really key for when you have rotating residents coming through your department. So if your medicine resident comes down and doesn't feel like what you're doing is relevant to their future career, they may not really be engaged. You can engage any off-service resident or medical student going into any specialty by teaching them things that will be relevant to them in the future. they really need to understand how the material applies to either patient care or them. So this is an example of an email that we get on a weekly basis that is broken down by discipline and on one of our sites that tells us how much money each individual that I've blacked out here on each of the lines has lost the department by either incomplete or poor documentation. So I will say that no one here in my department, I think, was really focused on documentation until we started getting emails realizing in a single week, we'd lost the department $4,000 or $2,000. And so very quickly, people understood how material was applicable to them and how it applied to them. And they became much more engaged in learning how to do this better. Lastly, you have to get your learners involved. It's very easy when you're busy to simply give people the answers. It's very natural to just want to share what we know as people who know more than those who are presenting to us. I would encourage you to resist that. This is really a great opportunity for you to ask questions, pointed questions, that are not making learners feel badly, but that are giving them the opportunity to participate in their own learning. Great teachers really know how to educate students by keeping the focus on the student or the resident or whomever, because every student is going to come to you with a different level of knowledge. And what you may decide you should share to one student may be irrelevant to another who already knows that information or has a PhD in that topic, right? And then they might know more than you about it. This is really, I think, one of those moments where you need to go out ahead and make sure that your students know when you ask questions, you're not pimping them, you're doing a little search to uncover those opportunities that you can fill in for them in the future.
Okay, so I'm going to start talking about how are we going to actually do this. And we're going to start with actual teaching methods. Methods that are tried and true that we can fall back on in the emergency department and use them to teach our residents as we try to navigate through a busy shift. So there's a little bit of literature on how to try to do teaching clinically. And it's pretty vague. It says that we need to have bedside teaching, but no one tells us how to do it. And no one tells us how to incorporate it. It says that we're adaptable and that we can help with having teaching methods to learners and their experience level and patient acuity, but no one teaches us how to do that. And if anything, they're showing us that as overcrowding increases and the pressures to meet our metrics are increasing, our formal bedside teaching is actually decreasing. And again, as we talked about it, the crowding in emergency departments are a direct impact on how well we're able to teach our learners. So one of my favorite things to do is prepare my learner. I like to say, literally, I'm going to teach you something now, or we're going to learn something together now. I think when I prep them, and then later on I ask them, what did I teach you today? They actually remember. I spent 20 minutes with one of my senior residents going through aspirin and ACS with a resident once, and when my senior asked the resident later, what did you learn today? They couldn't tell him. So it's very important to say, we are teaching you now. It actually makes them stop and look at you and prepare to listen. Another tried and true is the SPIT method. So this is where you're actually working with a resident and you're discussing patient care, and you ask the resident what is the most serious, what is the most probable outcome, what is interesting, and what is treatable. You can use a very simple case and have a really good discussion about the possibilities and what you're going to do and what you can do. Use rounds. I don't know how many people actually round or do computer sign out. I try to use rounds, not every single patient, but I try to find a couple of moments during rounds to ask questions I may know the answer to try to teach and hopefully learn something myself or teach the residents something about patient care, or get the residents who are not presenting the patient to actually pay attention. I also use rounds at the end of the shift. I try to identify a few patients or a few cases that we can learn from, and then the oncoming residents will also learn about those things and hopefully will carry it with them throughout their shift. Another method is the 1-minute preceptor. You try to get a commitment from them. I get a lot of residents who want to say, well, it could be this or it could be that, and then they want me to make the final decision. Make them make a decision. It might be the wrong one, and that is okay, but they need to at some point make a transition to making commitment. And what is the evidence behind their commitment? And of course, the general principle, your symptoms, your physical exam findings, differential diagnosis, and your treatment, reinforce, and then guidance for errors or omissions. And then guidance. Don't make them feel bad, just guidance. And then bring it to the bedside. Some of our resident feedback has always been that they really love it when we come into the rooms with the patients. This actually surprised me. I do bring the resident in with me. We always tell the patient, though, that we are going to do teaching. So the patient understands what we're discussing and why we're discussing it. I have never had a patient not want us to do that. They tend to really enjoy it. And it makes the resident feel like you're actually really engaging them. One of my favorite things to do is to research answers to questions together. Lots of times the resident will say, well, I read online, or I read on this website, or this podcast said something. So go through and see what they're referring to, and also showing them what I use. What do I refer to? I need to look up things. What are my tried and go to? How do I evaluate information on the internet and make sure it's actually applicable and actually is embedded on some level? And of course, new studies. I'm sure all of our residents love to discuss with us the new studies and how they want to do this. And should we consult this person, or should we prescribe this medication now because the study showed X, Y, Z? I think it's very important to make sure I know what that study says and to actually evaluate that study in real time with the resident. One of my favorite go-to lines is, that sounds really interesting. Go get me the study. Let's talk about it. And I think it's really important because I can either learn something, sit down with them and go through the study, or I can teach them why we can't quite start doing that yet because the validation, the statistical power isn't quite there yet, or the study itself says it needs to be bigger study or have more power. So it's really important to teach them how to do that before they start using it in their medical practice. If they're really busy shift, there's always a delayed teaching. Email them or text them a patient follow-up. Let them know what happened after they left shift, if they're on a 7 to 7 and you're 3 to 11, just so they know how to close the loop. I sometimes will email articles that we discussed during our shift I wasn't able to get to. And of course, always saying a teaching point, especially the resident came off shift and you're still there, just what happened and the teaching point on what we did and the intervention that we discussed and how the outcome happened. A debrief is also really important. In critical care cases, an ideal time to talk about those. Not only can you talk about medical content, and you also can teach emotional intelligence. Critical care cases, especially when the outcomes are not what we hope for, impact not just the doctors, but also the team that was involved, both nurses and techs. So you're also going to be role modeling how to be the leader of the ship to your residents, how to lead those debriefs, and throughout the year, especially for your senior residents, start that transition so that they are leading the debrief and teaching them the emotional intelligence to take over as leader so that when they leave, they are ready to take over when they are the attending physician. Real briefly, this is an example shift. I find that if I sit down and actually think about this before I go into the emergency department, I am more likely to do it. And all of a sudden it's not 2 p.m. and I haven't taught my residents a thing. I try to talk about 2 teaching points on rounds. I always ask the resident to identify 2 teaching questions that we can discuss during the shift. That takes a huge load off my shoulders because now I know what to teach. If I don't have anything to teach, I use the SPIT method during presentations, and I always try to go bedside with my residents. Towards the end of the shift, I start looking at the patients who are wrapping up, who may still be present during rounds, and trying to find really important teaching points for the oncoming residents and the off-going residents. And on follow-up, if I have an article I want to email out to everybody, I always do. And sometimes we'll send pearls to residents, maybe validated studies or a way to look up things for the teams for follow-up.
So now that Leah has given you all some idea of how to structure your teaching or structure your shift, let's all talk through how we can find those moments during our shifts that can really be teachable moments. So I like to think of finding teachable moments in these 4 big buckets. So from charts, from the presentation as a whole, but then specifically from discussion around management plans, and then lastly from bedside observations. You can get a lot from looking at your residents' charts, and you can do this while they're doing something else. They can be in the room seeing a new patient, and you can be looking through their chart to see whether or not, let's say, they've met the documentation requirements that would be needed to bill critical care, or that we needed to bill a level 5 encounter. This is a great opportunity for you to spend some time teaching residents about billing requirements. Many of our residents say, you know, when I get out there, I didn't realize I had to put the number of minutes in my critical care chart. And this is extraordinarily relevant to our learners. And they often don't know that they don't know this, or that they're missing a key element, or that, you know, pulses actually go in the cardiovascular exam and as opposed to the extremity exam. There's a lot of rich opportunity that you can find in the documentation regarding billing requirements. You can also really get a lot from looking at charts about how residents organize their material, whether or not the HPI seems coherent and organized, whether or not they're putting things in the HPI that really belong in a certain area, whether or not there's certain materials such as a neurovascular exam in your orthopedic injury patients. This is, you know, something that often is missed in many charts, and is a very well-known area for litigation, where they don't document that there was a pulse before doing a reduction. Did they document whether or not there was a tetanus, or was it a tetanus-prone wound based on the exam? Would you be able to tell just from reading that chart that it was not a tetanus-prone wound? From presentations specifically, you can focus on, are they organized? I often have a lot of senior residents who want to go, who are supervising, let's say, the intern, who want to go and see the patient before they hear the presentation. They often can't tell that the student or the intern is disorganized because they already know all the information before they hear the presentation. So this is a great opportunity to hear a fresh patient you haven't seen before and have the thought in your mind, could I follow this presentation? Are they rambling? Are they including something in the HPI that really belongs in the physical exam? Do they need to be more focused around a specific portion of the history that really isn't present, that doesn't let you understand that they actually asked the pertinent information? Lastly, for me, I really love having residents use problem lists. And so for people who've never done this before, this is taking all of the active issues your patient has and listing them one by one, whether or not they're related or not. So your patient in DKA might, you know, have dehydration. They might have an infection. They might also be hyperkalemic from, you know, the acid-base disturbance. And are you treating some of those? Are they simply related to each other? Encouraging your students and learners to really think about all of the active problems independently and talk through what they're doing, either from a diagnostic or a therapeutic standpoint, can be really helpful. This is also a great little paper that talks about student presentations and gives you some examples of problems and how you can help them overcome those pitfalls. I highly recommend it if you haven't read it yet. From the management plan, this is, I think, where we often do a lot of our teaching. Obviously, if they're wrong, it's a no-brainer that we have an opportunity to teach. But this is a great opportunity to really go and dive deep into the details of the medicine. I'd encourage you, before you do this, to really talk to your learner about the fact that for some, it gives the feeling of pimping, right? This is where you ask questions to uncover what they don't know. And I often will say to my students and learners who are more junior, my seniors know that I do this and understand why. But if it's the first couple times I work with someone, I say, look, I'm going to be asking you some questions during our time together. And this is an opportunity for us to find out what you know and what you don't know. Because what you don't know provides an opportunity for me to teach you something. And that's the whole point of us working together today. And I find that students and learners are much more open to being asked questions and not feeling bad about being asked questions when they don't know the answer, because they know that it's an opportunity for learning. So if they tell you the patient is stable, what do they mean by that? Do they use certain criteria to determine what leads to stability or instability in certain conditions? How did they evaluate the EKG to determine that it was aberrant conduction? Did they look to see that they don't already have a bundle branch block on their prior EKG? Why did they specifically choose a certain medication? Are there other medications that would also be appropriate in that situation, but that just based on preference, you could choose something else, versus based on some evidence, they could choose something else? And then lastly, for management plans, this is probably one of my favorite things to do, just change the situation. So what if you were at a community hospital? Would you do something different with that patient who's having a STEMI? What if the patient was 85 and not 35? What if this patient was hypotensive with the same exact presentation? What if the same patient had diabetes or they had a known heart murmur, right? This is a great opportunity to talk about that we no longer use prophylaxis for dental procedures or for Foley catheters for these patient populations. So really just taking a simple case that has really not a lot to teach around it and changing it, or changing something about the patient to provide more depth or breadth to your opportunity to teach material. Lastly, Leah talked earlier about going to the bedside. You'd be very shocked at what your learners can, progress through residency and still not be doing correctly. So, do they have a disorganized history taking approach? When you can't figure out why your learner can't do something, going to the bedside to them to really understand what they do when they're not in your view is a great opportunity to be able to diagnose your learner if they're having a problem, but also find a great pearl to be able to give them about their history taking skill or their physical diagnostic skill. Going to the bedside to do a musculoskeletal exam is a gold mine, because many of our learners don't have great exams for the knee or the shoulder. Thinking about how they communicate. Do they appear to be able to read the room when there's something that just doesn't feel right? And then of course, we're always going to be at the bedside for procedures based on supervision and need for billing. But definitely a key thing to remember, even for procedures we think they're adept at, going to the bedside when they're doing a lac repair to really just get a key moment to see how they do the block, what they do when they're doing a stitch maybe they're not as comfortable with.
So this is one of my favorite slides. From our residents, we've actually asked our residents, can they please give us feedback on what they would like us to do during a shift? And we pulled the biggest ones from there to talk about with you guys today. The one that I like the most and actually helps us out a lot is discussing our learning goals for the shift. I spent a lot of time with my fourth years going through EKGs because of course they realize all of a sudden in a few months they'll be reading them all by themselves without our little signature on top. And they also want to know how to be efficient, or they're having a difficult conversation with the consult. How do I navigate these waters? How do I talk to the consultant and have a good conversation? Teach me how to work with someone so I get the best thing for my patient. They also want us to discuss our plans when they present them to us. So essentially as they're presenting and they want to know if we change the plan, why are we changing it? What is the evidence behind changing the plan, or what's the consensus? What is your thought process? What did you find on the physical exam that I did not find that makes you want to do something? I think it's very important not to tell a resident, humor me, or because I said so, but to at least say, this is why, and here's the evidence, or here is my exam findings, and these are my concerns. We already discussed debriefs after critical care. They are just a gold mine, and the residents really want to learn how to be that person, how to lead their team through a rough case, and be the person that their team looks forward to and is happy to see when a critical care happens. And something that I think we all need to do is discuss the emergency medicine literature behind maybe very basic decision making. An example is using Levophed or Norepi for Oppressor as a first line. We don't tell our residents why. They know that we want them to order Norepi. And so having them read the SOAP trials and understand the evidence behind that decision will help them remember in the future certain things. So in summary, as we all know, the ED is a challenging place to teach, and finding your way to teach is in that environment is very important. Understanding adult learning principles will help you be a better teacher. They are not students, they're adults, and the environment is very different. Know your methods and practice them and find your fit. Every method may not work for you, you may not like one, But you find that one that you really enjoy using, then you'll rely on it more and more. And recognize your teachable moments. They are there. Let your resident know that they're being taught, and use them all the time, and use that wealth of knowledge that they have in the charts and everything that's going on to teach them in that real moment. And learners are your resource too. They can help you, and you can help them in real time by understanding what they want to learn, excuse me. So they tell you what they want to learn. That helps you, a huge weight off my shoulders when I know exactly what we're going to be teaching during the shift, and I can focus on that. So just a couple of tips. Plan before your shifts. If I go in knowing what I'm going to do, I will most likely do it. If I don't do anything. Engage the resident and always be consistent. Let them know how you're going to be teaching, what you want to know, and what they need to know when they come talk to you. And do what works for you. Find your comfort. And please remember, you're not omniscient. I do tell my residents sometimes I don't know, but also is a great opportunity for me to sit down and look things up with them and figure out the answer with them, so they know it's okay to say the same thing to me and then go look up something.
We hope the presentation has been helpful and offered you at least 2 or 3 things that you can go and try on your shift. And I think we will open it up for questions.
First of all, thank you both very much for that presentation. Very, very informative. We would like to open the floor up to our participants for questions. She had a question. So I really liked that slide that you showed earlier about showing learners how things are relevant to them. And I think you put up a slide of a report that is presented to your physicians about how much money they cost the department due to down codes from inadequate documentation. I noticed that the residents are included on that report. I wonder how that is received by the residents.
Yeah, before that report went out, we told the residents it was coming. And I think that, they were nervous about it. And in the beginning, say there were always a fair number of residents on that sheet. And I will say now it is very rare to have a resident who ends up on that sheet. So there are multiple columns. The most updated report has or incomplete charts in a very short window, so like under 7 days, which are still acceptable from our standpoint, that they can still be working on them. And that's where we see the residents have some incomplete charts, but there's almost no residents who end up in the latter columns where it would really be considered delinquent. And I'll say that having the ability to see and find residents that actually need assistance in developing more efficient documentation practices has allowed us to help those residents better, just as residency leadership. The peer pressure of not being on the list has been great, both for the residents, but also for the faculty, because the list includes every single person. So if you're on there as a faculty member, all the residents can see you're delinquent, and vice versa. So honestly, I think the people who are more uncomfortable with it are the faculty, because they're not looking so hot to their trainees every week. The residents, I think, have really embraced it and stepped up. And it's extraordinarily rare that we actually find residents on there anymore. And when they are, they're residents that we recognize are struggling, and we immediately intervene to try to help them build better, efficient practice.
Wow, I think that's great. I actually think it's great that the residents have first of all internalized it and are no longer on the list much. And I actually sent a copy of that to some of my fellow associate chairs in our department, curious what their thoughts about if we should do something like that in our department. So thank you for sharing. A tremendous thank you to our speakers, Dr. Regan and Dr. Bright. Thank you for your time. Thank you all for joining us. I hope you enjoyed this session of Court Connects. Remember that the session is recorded and is available on the Court website, and we are looking forward to seeing you at our next Court Connect session. Thank you so very much. Have a wonderful day.
Thanks, Moj. Bye.
Thank you. Enjoy the rest of your day. Bye.
You as well.